We are live.
Thank you, Sandeep. Welcome to Indian Arthroscopy Society webinar number 107. Meniscus repair, where are we today? It's an important topic which we are going to discuss today. And in this master class, we have Dr. Peter Verdonk. He's Gast professor, Department of Ortho Surgery from Belgium. He's also president of the Belgium Knee Society. Let me welcome Dr. Peter. He's a master in meniscus. His work on meniscus repairs and meniscus transplants are worldwide known to all. Shreyash will kindly introduce our guest speaker today, and then we follow it by the presentation of Dr. Peter. Shreyash, please.
Hello everyone, and welcome to this webinar on meniscal repair. Where are we today? With increasing evidence and recognition of the importance of the meniscus of the knee for joint preservation, there has been a surge in surgical techniques for the last decade aimed towards meniscal preservation. And today we have Professor Dr. Peter Verdonk from Belgium, Europe. He is an internationally renowned knee surgeon with a special interest in meniscal and cartilage surgery. He is a full-time knee specialist at the Antwerp Orthopedic Center of the Monica Hospitals, Antwerp and Deurne. He's been a visiting professor at the Antwerp University Department of Orthopedics since 2015. He's also a visiting surgeon at the Aspeta Sports Medical Center in Doha, Qatar. Previously, he worked as head of the clinic at the University Hospital Ghent up until 2012, at the Municipal Hospital Roeselare as a consultant till 2012, and thereafter as a senior lecturer at Ghent University Department of Physical Medicine and Orthopedics. He studied medicine at Ghent University, where he graduated with highest distinction, and afterwards his specialization in orthopedics at the Municipal Hospital Roeselare. And subsequently he did further training in knee surgery with Professor Johan Balhams and Professor Philip Nerat. He's also obtained his PhD at UGent with the subject, the human meniscus characterization, tissue engineering and transplantation, under the guidance of Professor G. Verbruggen. In 2004 and 7, he was selected for the prestigious traveling fellowship of the International Cartilage Repair Society and the ESCA and arthroscopy, with long stays in several renowned orthopedic centers in the USA. He has authored more than 100 international publications and regularly speaks at home and meetings abroad. He is currently also the president of the Belgium Knee Society and is involved in a number of national and international scientific organizations, ESCA, ICRS, ISAKOS, AOSSM, to name a few. Really, he is one person who has done a lot of work on this topic, and on behalf of the Indian Arthroscopy Society, we are delighted to have him, and I welcome him, and I would kindly request him to please share his screen and give us a talk on meniscal repair. Where are we today? Thank you.
Thank you, colleagues, and it's a pleasure for me to not travel to India, but do this on a virtual way. I was asked to tell you a little bit more about dealing with difficult meniscus injuries in athletes. Sorry, let me just, no, okay, there we go. There we go. Is this clear?
Perfect, perfect.
Perfect, thank you. So I'm going to tell you a little bit more about my experience now in dealing meniscus repair, specifically in athletes. We are now more and more aware that athletes push boundaries, and I think meniscus repair in this patient population is kind of different than the day-to-day meniscus repair that we do in our general population. So bear that in mind when we go through these indications and lessons I learned dealing with these kind of patients. Let me just start to share with you one of my statements, and I think basically what I've learned so far is that some knees are prone for meniscus injury. Basically what I see is that sometimes you can predict that a patient or an athlete, when he or she walks into your office playing volleyball or football, basically you almost sense that sooner or later that knee or that meniscus will fail. And it's very important to understand what made the knee fail or the meniscus fail before you start treating them. If they just fail playing volleyball, then repairing an injured meniscus in that type of situation most likely will fail again. And it's very important to understand that. So in order to be successful in meniscus surgery, we thus have to make that specific patient and that knee stronger than the original if you want to be successful. Being as good as before, because before it failed, is just not good enough. And therefore, it's very important to understand that if the native meniscus was torn during a specific sports, and you want to go back to that specific sports, the repaired meniscus, which I think is always weaker than the original one, I believe that's very often it will fail again, tear again during the same sports. And this implies that the repaired meniscus needs to be stronger than the original. And I don't think that at this point we are there yet. I think there still needs to be a lot of research done in this area to basically improve healing in the soft tissues. If you break your bone, the bone is stronger than before. If you break a soft tissue, the soft tissue is basically, my experience, never as strong as before. And therefore, there's still this big eternal debate about resection and repair in athletes. And basically, if you resect as a surgeon, you accept that we failed in dealing with the repair. But if you repair, very often these athletes come back again in your office with complaints and a failed repair. And therefore, this eternal battle is still going on. It's a very interesting battle. I accept this battle every day when I deal with my patients, and I try to make the best choice for them, but still do the research to improve my repairs and improve my resections in these athletes. Because on the one hand, we are all aware that if we're dealing with a meniscectomy, that you can have detrimental, catastrophic evolutions after a meniscectomy. In the short term, swelling, pain, rapid chondrolysis on the lateral side. Long-term complications, osteoarthritis. But also if that meniscus injury is associated with a ACL tear, we know that the stability will be affected if that meniscus is not there. So we need to push repairs basically in the ACL deficient knee also, but sometimes it's just impossible. And that eternal battle is very important to understand, because on the other side, if you repair, there's a complication rate, there's sometimes joint line pain, the rehab is complicated, and there's going to be failure and reoperation again. So basically all of these come into play. And if you look into the results, and this is a very good paper by Rob Brophy, looking into partial meniscectomy and repair, if you consider reoperation rate a failed surgery, which I don't consider as failure, but a lot of our colleagues consider them as, well, needs to go back in, so therefore it's not that successful. But meniscectomy clearly has fewer reoperations than repairs. However, in the long term, every repair is significantly better than a resection. And so again, there's no real great answer in the literature. And what I do see is that if I'm dealing with very young athletes, I will push repairs definitely in that patient population. But if I'm considering an established athlete in the prime time of his career, most likely, and I'm talking medial side, it will end up with a meniscectomy. And these things are still evolutionary. I mean, I hope there's going to be an evolution towards repair way more than resection, but sometimes we need to also accept the fact that repair basically also fails in a number of these patients. So what have I learned over the years? Well, basically what I learned over the years, and I'm talking medial meniscus injuries in athletes, is I look at my MRI. I generally do not make any decision on repairability during the arthroscopy. I need to have an MRI. The reason I believe that I need to have an MRI is that basically when you do a scope on the medial side, you always overestimate the fact that you think it's going to be in the red area, especially in the back. And it's very often it's not. Look at these videos on the right side. You'll see that this looks a very red, and it is. But in the back of the same knee, you'll see that it's a complex tear with a horizontal component, and it's in the white on white area. There's nothing red in that area on the lateral side. And this is the medial meniscus. It's going to be red here, but on the back, it's going to be white. And that's why we have so many patients in the office and in the literature failing medial meniscus repair because we thought it was red on red, but in the back, it's always less red and it's more white. And therefore, I think many of these patients are repaired during arthroscopy, but I'm wondering if that's the best choice. And so more and more, if this is the configuration, I'm going to propose a resection in my athletes. That doesn't mean that I'm going to propose a resection in my normal population. In a normal population, you can afford to reduce the lifestyle of those patients, the activity levels, but you cannot afford that in your athletes. And that's the difference. And it's very important to understand that. This is also very recent data. I don't know if you guys are aware of it, but I was recently in a meeting with Robert Śmigielski, who's a world-renowned orthopedic surgeon, but also a very nice anatomist. And he showed me this picture, and it just flabbergasted me. The vascularity on the medial side is significantly lower than on the lateral side. This is medial, this is lateral. He called the medial meniscus the miserable meniscus and the lateral meniscus the lucky meniscus. And that's most likely what we see in the office when we're dealing with athletes. Is it might not just be biology as a sense of repair inside the knee. It might also be the fact that on the medial side, there's way less vascularity, way less healing potential. And that might just explain why we're so bad in dealing with medial meniscus injuries and why we're so good in dealing with tears on the lateral side. And this is very recent information that explained my observation in my clinical practice in a number of patients. So my medial meniscus repair indications in athletes have become way more selective. I still believe that if I'm dealing with large meniscocapsular tears and ramps, and basically that is every lesion that you can observe from the trans-notch view. So if you go in the back and you look on the posteromedial side and you see a tear, that's going to be in the red area. That's going to be a perfect indication for repair. Roots, I think, although they're rare on the medial side in athletes, they're a definite indication for repair because a root is the end of the ball game. It's the end of the game. That meniscus is dead, is infunctional. And so repair might make sense, but it's going to be very hard. And also in young athletes. I'm dealing with athletes in two categories. They're either established athletes. And so those are guys that have injuries or ladies that have injuries when they're 25, when they're in the first team and they tear a meniscus. It's going to be a different ball game than if you're 16 or 17. If you're 16, 17, you have a whole career in front of you. And we know that long-term detrimental effects of meniscectomy are there. However, if you're an established athlete and you tear your meniscus, that's a different ball game. You want to go back fast to the game. So partial meniscectomy, we need to accept that also is well tolerated in established athletes in the short term. So medial meniscus ramp lesions, I'm going to share with you some of the knowledge that we have. I think all of you have seen these. There still are very challenging lesions, very often associated with ACL injury. It's basically Bertrand Sonricotet, who's a good friend, that introduced or reintroduced these into our area of attention. They're always associated with an ACL injury. His incidence, which he reported to be over or close to 40%, is something that we don't see in my athletes. And I'm dealing with a lot of soccer players too. The incidence in our patient population is about 20%. And I do believe that if you're lucky and if you don't operate these ACLs within a couple of days, many of these injuries will already be healed by the time you do a scope at 4 to 6 weeks. So the majority of our patient population gets surgery at 4 to 6 weeks after the initial injury, not within 24 hours. And I think that makes also a difference. But there are important stabilizers in the ACL injured knee, especially in the AP direction, but also in the rotational direction. And so if you're considering rotational stability, then I think that a ramp repair makes sense to really address rotational stability, but that also makes a lot of sense to address the stability issues also with a lateral tenodesis or with an ALL reconstruction. So whenever I have a ramp lesion, I'm going to do a lateral tenodesis. My indications for lateral tenodesis in conjunction with ACL have risen from 30% 5 years ago to now almost 70–80% in the primary setting if I'm dealing with a rotational instability and a meniscus injury on the medial side. I do look at these injuries with an MRI again. I believe that the scope is interesting and important to visualize and identify the lesion, but you need to have a good MRI, which will make your surgery a lot easier, which will make your plan a lot easier, and therefore you're more comfortable within the surgery to deal with these. So this is a typical meniscus ramp lesion with a significant line, very meniscocapsular. There's going to be some subtle bone marrow edema at the medial posterior tibial plateau. So look at for these, because if you have these, there's going to be a definite crush of that meniscocapsular compound on the medial side. Sometimes the tear is more in the body. You can see here that this is borderline red. So this is still very nicely repairable. So go for these. And so all of these have different aspects, but I think, and with my MRI quality that I have, 1.5 Tesla and 3 Tesla, I think we can observe most of these medial ramps lesions easily before surgery. If you have to do them with the arthroscopy, you just realize that you can miss them when you're just doing the anteromedial and anterolateral portal. You might recognize the undersurface aspect here, but you really need to go deep inside the knee and the posteromedial corner. So at the superficial area, you will miss these lesions very often. So you have to go in the back. The way I address these lesions is I've been working some time now with certain companies on developing tools. And I must admit that everybody is still struggling with repairing these. So we need to reduce the complexity of the surgery in order to make them well addressable and successful in their repair. I use the MVP, which is a very neat instrument, and I will show you in a couple of minutes. This is all inside posterior repair through a low posteromedial portal. So if you address these lesions, you go with your scope to the posteromedial aspect underneath the PCL, you turn left or right, and that's where you see the lesion. You're going to have the knee in 90 degrees of flexion. You're going to internally rotate the foot, so you're going to see that posteromedial aspect. Then you introduce a needle. If I'm doing PCL injury, I'm going to have my needle high because I need to look low. For my medial meniscus ramp lesion, I'm going to have my needle low and my entrance low here, as you can see. So needle as a guide, I introduce it low and parallel to the meniscus. That's where I want to be. Then I'm going to introduce my 11 blade. This is my needle. This is the meniscus. This is the gap, the tear, and this is the capsula. Again, capsula, tear, and meniscus here hidden. And the instrument I use is this MVP. MVP is basically a double barrel instrument. It has a curved needle. It comes with a right and a left variant, and it comes with a pusher, which introduces a suture. And you're going to see here, this is the phantom medial meniscus, and I'm going to show you how this works. It's pretty easy. So you introduce it through the posteromedial portal, low. You just puncture, and I do it from the top to the bottom. Bertrand addresses it slightly different. He goes from the bottom to the top, but this is for me easier. So I introduce my needle, I introduce the eyelet, which is just in place there, and then you introduce a suture in there in the eyelet. You retract the plunger, and that's where you have your suture. And that's how easy it gets. And then you pull it out, and you just tie your sutures. And it's a very easy way to address these posteromedial corners. I think for me, it's the easiest way to address them. Let me show you now how we deal with them in reality. So this is the instrument. You grab the medial meniscus. You can actually reduce the whole thing. The needle comes out. This is the meniscus. This is the tear, and this is the capsula, tip of the needle. Open up the eyelet coming out of the needle. And then you introduce your suture, and I use resorbable sutures in these cases. I use a 0 or a 1. You pull it through, and then you just tie and push it, and there's a knot. And you can nicely reduce these injuries using an instrument, and I think we significantly reduce the complexity of the repair in these using an MVP. What I did before sometimes, and which I no longer do, and I'm not blaming any fast fix or all inside device that you introduce, but please don't do these in ramp lesions, whatever the brand is, because they're non-resolvable sutures, and you're gonna have a jigsaw, a cheese wire effect. So I don't do these from my anterior portal, and I don't do a vertical repair. If you want to address these, do a horizontal repair, but don't do the vertical repair with a non-resolvable suture. The reason is this, and this is an observation that I had in quite a number of athletes in some time ago. So this is an ACL ramp lesion. You're going to see the ACL torn. You're going to see the ramp here. There's that ramp lesion with some kind of inferior aspect, a small tear there. So what I did is I tried to suture it vertical, and I think I did a nice job in suturing this this lesion. But what happened is that patient got back to running, and it's a she. She came back to running, and a year after the fact, she just suddenly during the running she heard a pop, and the meniscus was just in bits and in pieces. It just exploded around that vertical suture, and you don't want to have these kind of catastrophic effects. You see full radial tear on the back of the meniscus because of just the cheese wire effect of a vertical non-resolvable suture through the meniscus. So most likely it didn't heal perfectly, and then the suture just cheese wired, and I had to do almost a full meniscectomy in the back. This was almost full thickness. And so you see that these are cases that you don't want to have in your athletic population. I think going from the back all inside with a resolvable suture has so far been my best approach in these lesions. Another type of lesion that you're going to see in athletes quite often is the medial meniscus degenerative lesion. This is typically 14, 15-year-old boys that do a lot of flexion activities. They dance or they do ground sports, and they're in that period of their lifetime where the soft tissues are very swollen. They're sensitive for injuries, especially in the high flexion sports. So this is a typical meniscus. You see the high signal all throughout the posterior medial horn of that medial meniscus. This is the same guy, open physes, close to closure on the tibial side with a complex horizontal tear in the back of the knee on the medial side. And so, of course, you're going to try to heal these. Of course, you're going to protect and prevent and keep that meniscus for the rest of their life inside their knee, or that's at least the purpose. But to do that, you need to explain to them that they need to avoid hyperflexion, and they need to be very careful in at least 6 months to a year after injury. So this is just the way we address these. We want to put a lot of sutures, but I'm going to use inside out small needle vertical sutures above and below the effect. And so therefore you need to know these approaches, posteromedial approach, posterolateral approach. You need to be very comfortable with these approaches in order to deal with these lesions. And so again, I invite everybody that's dealing with these to have this kind of approach at hand and to be comfortable with it. You can advance your healing. We can use fibrin clot, which is studied extensively by Arnowski. It's cheap, but it's very hard to deliver. It's always complicated when you start doing these, especially if the surgery is not planned. So you have half an hour for the scope, and then suddenly you're busy for an hour preparing a cloth and delivering it into the defect. But it's worthwhile if you're dealing with very young patients, I believe. Use the fibrin clot. There's a lot of research on PRP, and it's still very expensive, hard to deliver, and variable, and the data is neutral. There's some people that use them, and some people that just are not very pro. If I'm dealing with a professional athlete, I'm gonna have these and I have to do a meniscus repair. I'm gonna add always some PRP also in the post-operative schedule in these athletes. You want to give them whatever you have at hand to increase repair potential in these high-level athletes. Meniscus wrapping, this is work from Tomasz Piątek, which I think is very interesting and I think is really pushing the boundaries of repair. However, today it's very early to tell, but he's dealing with these very sometimes degenerative lesions, wrapping a CMI or a geistlich sheet on top of the meniscus and creating some very nice data and showing repairability even in the white on white area. But this is not for everybody. And I think we need to really push this type of research further to provide really clear clinical data for our patients. The lateral side is something completely different. It's a different ball game. It's a different animal, and my treatment is different. And you need to be aware of that. I'm way less selective. I'm going to repair almost everything on the lateral side, even in my athletes. Reason is that once you start doing a lateral meniscectomy, the career of an athlete is always shorter. And that's what I tell them. If you have a lateral sided injury, you're going to have a shorter career. So therefore, it's worthwhile doing a repair, especially in a full radial tear, because that's just a blow up of the meniscus. That meniscus is lost. You need to do something to that. Even if it's not 100% successful, it's going to be better than nothing. Hypermobile posterior horn is a perfect indication for repair. Lateral sits is an excellent indication for repair, and again, young athletes. And so these radial tears are very strict indications for repair. Although they're challenging, I think doing nothing in these cases is most likely worse than doing something. And this is a typical injury, some bone marrow edema, and then a full radial tear, typically at the midsection anterior horn. That's where these guys will tear their meniscus. You will see this also here. This is going to be the typical section of a meniscus, either associated with ACL, but sometimes also not associated with an ACL injury. So lateral meniscus tear, if we're dealing with the radial, the full radial lateral meniscus tear, we're going to do what we call a hashtag repair. So you're going to need some zone-specific instruments. You're going to need cannulas. You need these instruments inside your OR. You can do it also outside in, but I think inside out is a lot easier. And this is a typical injury. So full radial tear on the lateral side, typical area, mid-body, anterior horn. You're going to have these injuries here on the sagittal views. This is a little bit further down the series, but then there is a full radial tear. And sometimes you can miss it if they're small, but the full tear you're going to obviously observe all the time. And they're very often isolated also, sometimes with an ACL, but very often isolated. This is the area. So I don't believe that you can heal the inner inside, the white on white area, but I truly believe that if you can address the rim with a hashtag repair, you saved a significant portion of the function of that lateral meniscus. And this is the hashtag repair. So 2 verticals on each side and 2, 3 horizontals crossing the verticals. So this is basically a modified Allen Mason stage on the meniscus. And this is another patient showing you a hashtag repair. And they seem to be very stable. They do heal, most of them partially, but again, partial healing is better than nothing in a lot of these patients. That's why they call the hashtag. I always associate them with a microfracture of the notch. You want to have some bone marrow elements inside that knee. Something that I learned the last couple of years, especially dealing with athletes, is that some of these tears present early on with a small tear, and then they become bigger in 2 or 3 steps. And you do not want to be the surgeon at step number 3 when they come in with a full radial tear in their career. You want to really address the crack, the tear early on in the evolution, not too late. And what I learned so far is that very often, if you listen to the athlete, he comes in with an issue that it happened 6 months ago or last season. A small thing happened. After 4 weeks, he was back in the game. Then he had another landing. and then suddenly there's a tear on the meniscus, and then they go back to the play, and then a year later it's a full-blown tear, and you're dealing with a catastrophe. So you don't want to deal with the catastrophe, you want to go in. So my analysis is that it never happens at once or seldomly. There's always a couple of sessions, and if you're dealing with them in session number 1, most likely you're going to be able to prevent. So this is the typical, this is a Belgian national team soccer player which came in with this kind of full complex radial tear on the lateral meniscus. You see it's complex because it also has a horizontal component. It has a radial component in there. And these are very challenging cases you can see here. And then you end up with this type of situation where you have degeneration, chronic tear, and very little options except to clean it up and safeguard as much tissue as possible. But my lesson is that most likely in a number of times these patients come in with a small tear and then there's a crack propagation, which I showed you here. And I think, and that's what I tell my patients, even if I see a small tear, you better come in between seasons or in mid-season. We deal with these small tears and you regulate them, you clean them up, and you can go back to sports 4 weeks after the surgery, and you're going to be safe and happy for the rest of your lifetime. But if you don't deal with these small cracks, you're going to end up at some point with a bigger crack and therefore catastrophic injury in the career of an athlete. So basically the small tears, I'm going to be pretty aggressive and early treating these rather than to be confronted with a big tear. And it's always a struggle to explain to the club doctor and to the athlete why you should go in early on and not too late. Again, if you're a normal person, most likely you're going to survive a small crack and it's not going to propagate. But if you're an athlete, you're going to push it and you risk of having a bigger lesion and a more complex lesion. So you want to avoid crack propagation. Lateral cysts, very often with soccer players, but also with more older patients, more degenerative patients. And when I'm seeing these in my athletes or in my patients, I'm going to always associate it with an open repair. This is the approach. I do a small incision on the lateral side. You open up the ITB band. You use a shaver to clean up the lateral meniscus and the cyst. It's very easy. So use a shaver in a dry air situation. You go to the meniscus, which is there, and then you just put zero-sized sutures with a smaller needle, which are ideal, and you put 5, 6, 7 sutures across that meniscus on the lateral side. And that really works great. Most of these patients tolerate this kind of surgery easily. They're happy, and the cyst doesn't return back. So this is 6 sutures on the lateral side on a degenerative horizontal tear with cyst in my patient population. Root tears are still very complicated, I believe. They're high energy injury. They're very often multi-ligament injury or with knee hyperflexion while squatting down, but they're very rare in an athlete, and it's still a tough lesion. Although I think we should repair them, especially in the young patients. I'm still confronted with a significant failure rate and therefore still problems to solve and challenges to deal with. Clear meniscus roots, very often secondary with secondary degenerative changes in the ACL. It's very important to understand that intricate relationship between medial meniscus function and the ACL. So if you have a root and it's a chronic root, you're going to see also degenerative changes in the ACL. And so imagine the effect. So this is a root there. Imagine the effect when you're dealing with ACL injuries and roots, or the protection a medial meniscus have. There's the root there. And the degenerative changes on the ACL. So I'm going to deal with these. I'm going to suture them. I'm going to use a loop. A fiber link is what I called. I'm going to use a scorpion. I drill my tunnels from the opposite side. So if it's a medial root, I'm going to drill my tunnel from the lateral tibial side up to the medial horn. I think it's easier surgery. It's biomechanically makes a lot more sense. I'm going to drill a 6 tunnel. I want to have a big tunnel where I can really pull some of the meniscus tissue inside a tunnel and have some bony integration. I'm not doing two smaller tunnels. I'm not doing a single small tunnel. I'm doing a kind of big 6 millimeter full-blown tunnel to get some bone marrow elements and some tissue of that meniscus inside the tunnel. This is the approach, making a tunnel and then drilling and introducing a suture retriever. You can see already the degenerative cartilage changes. Then you're gonna use a scorpion and take two very nice bites. And you can kind of turn the instrument so you can see it, because the needle sometimes can get complicated when you don't see the needle or you scratch the opposing cartilage. And so the fiber link tissue is very easy because it has a good purchase inside the tissue and it has a loop inside, so that makes it very easy. There you can see it. I'm introducing now the loop. There it is. And so I'm going to do two of these at quite a distance, 0.5 centimeter and 1 centimeter. And then you just introduce these sutures. You pull them back into the tunnel. And you're going to have a very nice and stable fixation. Although we do this type of surgery, we must admit, or at least I admit, that I think I'm a good surgeon, but these things are really, really, really hard to handle, and you don't have a 100% success rate. And so a number of these patients might end up with a meniscus allograft transplantation if this doesn't work, or an osteotomy if this doesn't work. But for an athlete, this is a catastrophic lesion, and you need to really be honest with them if you're dealing with athletes and this type of injury. Nevertheless, if you look at the data, we are aware that it's clinically superior than doing a partial meniscectomy, but it doesn't prevent extrusion, and the progression of OA is slowed down, it's not stopped. And so if you're dealing with degenerative root lesions, then I think all of these are potential treatment options. Root repair, osteotomies, meniscectomies, replacements, and some of these patients will evolve if you're older towards total or unicompartmental knee arthroplasty. Meniscus tears are a potential kiss of death to the knee, might be career ending. Based on current outcome and introduction of advanced indications, we still need augmented repair technology and specific tools, and specific tools are easy. Augmented repair technology is not that easy, so there's still a need for a lot of research, but I truly believe that we are making progress in repair technology. For me, nowadays, it's the best situation and the best principle for repair is that you need to be prepared to repair. You need to be, your mind needs to be set, your surgical nurse needs to know what we're doing, your OR time needs to be good enough to do the repair, because if you have to do repair and you're not scheduled it, then most likely it's going to be a mess. So preparation is what counts. The actual repair is easy, but you need to be prepared. So it's brain work and it's prepping the knee. But we definitely do not need to underestimate the power of the meniscus. It's still a very important structure inside the knee, and it's very important to save the meniscus if possible. But also you need to have sometimes the dare to save the meniscus and accept failure. And this is what I believe is where we are now, is you need to dare to repair meniscus. But I also had lessons, especially on the medial side, that I pushed it maybe a little bit too far, and then you were confronted again with early failure. So you don't want to have failure also. And therefore, my indications for the medial side have changed quite a bit over the last years. Thank you very much for your attention.
Thank you, Peter, for that excellent overview on meniscal repairs. And I just invite my colleagues who are logged in to ask their questions, and I'll do so in the end. Thank you. Yes, Sandeep.
Yes.
Yeah, hi. Dr. Peter, I just wanted to know what is your weight bearing protocol after the repairs? Does it differ for medial meniscus and lateral meniscus and also root tears?
It doesn't differ that much. I'm still putting my patients on a 3-week non-weight bearing period, especially in roots. That is extended to 6 weeks. And most of these are followed up with unloaded braces for 3 to 6 months. So it's still a challenge, especially the root. I believe that if it works, it works. But if it doesn't work, you will observe early failure. For my peace of mind, but also for my academic interest, I do MRIs in all my roots at 3 months already to see if I do have a scar tissue formation, if I do see nice approximation of the tear, and I must admit, I'm not always that happy. I also stating that these are most likely older female patients. We're not talking athletes in that kind of situation.
So Peter, how is the compliance of unloaders brace for 3 months to 6 months, as you said?
I think I think my compliance is pretty high because the patients are really well informed of what we're doing and what we're trying to deal with. So most likely I will already discuss the rehab during the preparatory talk to the surgery, so they know that I'm a good surgeon, but half of the game is played in the rehab and in protecting what you did during the surgery. And if you notice that they smoke, if you notice that they're non-compliant, you can be the best surgeon, is going to fail anyway, especially these challenging indications. And so what I've learned so far is that smoking, for example, is a very significant factor. We recently identified smoking as causing triple failures in ACL repair. Triple. I think it's going to be similar with my meniscus repair, although I don't have the numbers. But soft tissue repair and smoking, very challenging.
Peter, question is that do cleavage tears make an important part of your surgical practice? You try to repair any cleavage, or you just leave it like that? You don't intervene on a cleavage tear?
So it depends on which patient population. Cleavage on the anterolateral side with cyst formation is quite a big part of my practice. And I deal with them very aggressively, meaning I do a scope, I do an open approach on the lateral side, and I suture. And I must admit, these results are quite impressive. On the medial side, my cleavage are either degenerative, and basically many of these patients will be treated conservatively. I'm talking 45, 50-year-old patients. They will be treated conservatively. At some point, maybe arthroscopically, and it's going to be a meniscectomy. The cleavage in the 14-year-old or 15-year-old athlete is a different ball game. In those patients, I will do repair. You need to explain them what made them fail, why their meniscus was overcharged, and supraphysiological charging and loading on that meniscus. And if they get it, if they understand, then I think a repair makes a lot of sense in this young patient population on the medial side.
Peter, there's a question on the chat about, do you have any experience about augmenting meniscus with synovium?
I have very little experience. I do believe that synovium is very important. And so abrading not only the meniscus tear, but the synovium in the area, not only the superficial part, but also the inferior part, and creating some kind of trauma mechanism in that area is important for healing. I haven't done synovial flaps or anything else in my clinical practice because it is challenging. But I do believe that if we could evolve that preclinical experience into the clinical world, it might add another tool to the toolbox.
Another question on the chat is that there's been a recent introduction of centralization surgery for meniscus extrusion at the time of root repair. What are your thoughts about it? Because essentially we're creating a ramp lesion to repair and centralize the meniscus.
These routes are, I mean, we're talking most likely older patient population. They're very, in my practice, they're associated with higher slopes also, patients with higher slopes, tibial slope. I think they're a challenge. And honestly, I haven't been impressed with the results that we have. There's a lot of Korean data on meniscus root repair showing that it helps to slow down OA. But basically, if you have a root lesion on the medial side and you're 50, it means at some point the end of the knee. And I haven't been able to save those patients. So therefore, I have a keen interest in meniscus implants. You know that there is now a US company which is called New Surface Active Implants that has these meniscus prostheses. And I believe that might be a solution to deal these patients that fail a repair or that have a failed root tear. You just take out the meniscus and you put back in a meniscus implant.
Mm-hmm. Peter, also there's been recent advocation, especially from Dr. Laprade and group, about using tunnels for large radial tears, which you showed. Again, what does it really help, or is just another way to skin the cat?
The tunnel approach, and I've had some very nice discussions with Rob Laprade on this. The tunnel approach seems to be very interesting. If I think it has a place, the place will be on the medial side because that's the stable compartment. I'm not sure that on the lateral side, where the meniscus has over 1 centimeter of mobility in high flexion, sticking it to the bone and immobilizing it makes sense on the lateral side. Dealing with these is a challenge. I haven't had radial tears in my midsection on my medial meniscus so far. I haven't seen that animal yet, but on the lateral side, it seems to be interesting, but I don't think it's the perfect solution. So I'd rather do a hashtag approach. I do admit that it doesn't work with everybody. You have to stop smoking, do a microfracture, do some PRP, immobilize those patients quite a number of weeks. But with an ACL, it works quite well. Without ACL, it's a challenge.
Now, another thing along the lines is when you bring the two flaps of the radial tear together on the white zone or the inner edge of the meniscus, sometimes you don't get an even or a balancing. So is it okay if we trim that a little bit? Or
yeah. In my experience, it's all about the rim. You need to keep the rim together. So what I do is I do two verticals, but I suture this vertical and this vertical. But then also I suture the ends of the two verticals to each other. So you basically close it down and then you do 2 or 3 horizontals. So you kind of grab as much tissue as you can. And then you say to the patient, stay quiet for a bit so you can heal. Because if you start moving and you start stretching, this mobile compartment is going to be complex.
Yeah, good. Roshan and Tejas, any questions from your end?
To augment the healing, I read the article in which they said instead of the fracturing of the microfracturing of the notch, we can do a needling in the gutter, like medial gutter or lateral gutter, and so the direct flow of the blood can nourish that repair in the meniscus.
2 seconds. 2 seconds. I just received a phone call from the hospital. Give me 2 seconds.
Sure, please go ahead. Yeah, Tejas, while he's answering that, let me just comment on it. So I used to do similar things, synovial abrasion for isolated chronic tears. But this drilling in the intercondylar notch, which is really not in the harm's way because it's anterior to the ACL, is really a great way to get the marrow into. Because I just did one this morning, and if you switch the fluid inflow, you'll realize that that whole flow of blood goes right where the repair area is. So there's no harm done, but at the same time, I've stopped. Perhaps I will stop rather using something like a PRP because this marrow venting seems to really do the job. Peter, over to you. What do you feel about this?
Well, maybe I've missed some of the discussion, but I do believe that the initial presence of marrow, and the more the merrier, is quite important. In orthopedics in general, the biggest progress that we're going to make in the next 10 years, that's my personal belief, is that we have patients that by definition, by genetical composition, heal very well. And you have patients, 10 to 15%, that never heal. And even with the bone marrow, they will not heal. The biggest challenge for me is to make that difference pre-op and tell those patients, like, look guys, it's going to be a waste of time, just do some kind of prosthesis. But for those that do very well, and I think very often athletes are good healers, especially the established athletes, a microfracture bone marrow element most likely is more than enough. There's some guys that I know that even push it, and instead of doing microfracture, they just drill a big tunnel inside the femoral notch, like a 6 or 7 tunnel, really to get that explosion of marrow elements. And you do see that the meniscus heals pretty well if you have a tibial plateau fracture or condylar fracture, and you have to go in and you do trauma cases, that they heal pretty well because of the explosion of growth factors in that knee joint.
Peter, there is a question. How often have you seen an anterior root tear?
I cannot remember 3 cases.
Okay, perfect. Thank you.
I think I remember 1.
So very, very uncommon. And
But
that may
for
be
me, very rare. In my patient population, very rare.
Okay, perfect. Yes, Shreyash.
Peter?
Yeah, go ahead, Roshan. Yeah.
Peter, you spoke about the meniscectomy in active athletes, especially the athlete which is in the season, and probably they don't want to miss the season. And in those situations, you like to do a meniscectomy instead of repair on medial side, so that the athlete goes back to his pre-injury status as early as possible. But what changes do happen in those knees when they go back to their pre-injury status immediately after meniscectomy? Because I think that is what is going to decide whether the meniscectomy is outdated procedure or is still in vogue. Because in general, when we spoke about meniscus repair, for years we were trained to do a meniscus repair, but of late we see all this international meeting, especially ISAKOS and ISCA, where people spoke about the meniscectomy in elite athletes.
Roshan, I didn't hear, it didn't come through.
So what does happen to those people who undergo a meniscectomy, especially the people who are in elite games like football players? So where you consider the meniscectomy, what does happen? What is the natural progression of those knees? Do they land up in early arthritis? Do they can cope up with the meniscectomy? Or do you have to consider for a meniscus transplant at maybe at the age of 50 or 45, whatever it is?
Okay, that's a very interesting question. The natural evolution after medial meniscectomy. Basically, there's very little data on it. My personal experience is that so far, since I'm still pretty young, The athletes that I treated, I don't see them yet at the age of 40. I'm 15 years in my practice. So I don't have the 25-year-old that makes it to 40. It's still short. But I do believe that most of these athletes end up with some type of arthritis. But I also believe that my athletes are basically the best healers around. And so the incidence of arthritis after medial meniscectomy is not that high, is not that problematic. You still have the osteotomy if they're a varus knee, if they're soccer players. When it becomes problematic is most likely if they have associated ACL injuries. But an isolated medial meniscectomy in a high-level athlete is most likely the best surgery that you can do. I've seen way more patients that came in with a badly indicated meniscus repair that lose half of a season because of the repair and the rehab. And then once they go back to the pitch, they fail again. And from a career point of view, from a mental point of view, being 6 months out of a game and then relapse into the same injury is for many of them catastrophic. Now it's a challenge to deal with them and to make the right surgical indication. Because if you're 16, and you're a high-level athlete and you're a big talent, I'm gonna do a repair because you have 10, 15 years of career ahead of you. But if you're 26, you're gonna have a meniscectomy most likely because you wanna be back rapidly into the game. And that change in my approach, it cleared up my approach and my treatment protocol for these type of patients.
About the lateral meniscus, in fact, you showed a wonderful picture of lateral meniscus repair. So what about the mobility? Because lateral meniscus is a mobile meniscus, and when we do repair of lateral meniscus, we make it a very stiff meniscus. So do you think we are trying to restrain the lateral meniscus from that mobility?
No.
After the lateral meniscus repair?
Yeah, so the repairs that I do either hashtag don't affect the mobility and also the lateral cyst, especially soccer players with hyperextension trauma on the shooting leg. Once you start doing those, it doesn't seem to affect their mobility. What I learned the last couple of years, and this is dealing with really high-level athletes. I mean, these are all soccer players, national level, international level. I'm doing quite some follow-up on these. If they have a small tear, we discuss with the club to maybe address it during the winter time or in between season or mid-season. But it's very hard if they don't have any symptoms, and so you don't treat them if they don't have any symptoms. But if they have the slightest symptom, I'm going to push them for a small treatment, which takes them 4 weeks out of the game. But in mid-season, that's not an issue, and at end season, is definitely not an issue with the slightest symptoms. And I don't want to have patients in my office again with a full-blown lateral tear at the highest level. I've had international athletes that missed out Olympics, that missed out World Cups because of a lingering issue on the lateral meniscus. And by the time they had to really perform, they were unable to perform because of that injury. And my experience is address it rather early. I'm not pushing it to address even the slightest detail, but address it earlier in the game and don't let it evolve towards a full-blown tear on the lateral side.
Peter, you mentioned about being very proactive in repairing the lateral meniscal tear. So what about the incomplete discoid meniscus in the adolescent and children? The thought up until some years ago was to just saucerize it and get a stable, balanced meniscus. Would we now should think of repairing it versus resecting?
Again, different game. I've definitely repaired a number of meniscus, but this is maybe one a year. My youngest patient with a discoid repair was 6 years old. She was handicapped. She had a constant click. Her dad was an anesthesiologist that I knew. So these are your worst nightmare cases because you don't want to have anything that goes wrong. But I still believe that saucerization is part of the solution. But very often when they present, they're going to have a tear at that anterior border of the meniscus, the discoid meniscus. So you need to take out the central bit and then try to repair the rim as much as possible. And they perform pretty well. I must admit, they perform pretty well. Again, I do open repair. My indication for repair is high, and my threshold for open repair on the anterior lateral side is very low. I mean, I think it's much easier and better and stable and steady and robust repair than the inside out repair.
Great. Now, one last question on the chat is that following a ramp lesion repair alongside an ACL, is your rehab any different?
Yes, it's slower, and I'm not slow on the weight bearing, but I'm slower on flexion. So where we are very aggressive on flexion and extension with my normal ACLs, we're going to be slower on flexion with my ramps, especially in the above 120. I mean, all these physical therapists, they like symmetry and they like pushing it to the. In those cases, I tell my patient, look, accept 10 degrees of flexion loss the first 3 months. You're going to be way better off than if you push it into flexion.
Great. IPS, we're done?
No more questions. Thank you.
Okay, great. Peter, really, we're very grateful for you to take time off and participating. Really, you've highlighted very important key points as per evidence that, although our enthusiasm for meniscal repair has kind of gone high in the last decade, we have to be aware that it is not without certain complications, unlike the lateral side, which is more forgiving because of the increased vascularity. And also the athletes are a slightly different breed of our population compared to sedentary individuals.
And there are also some ethnical differences that we need to study way better. And smoking. Don't forget the effect of smoking.
Yeah, thank you very much, Peter. It was indeed a wonderful presentation, and so nice. We would love to see you physically coming back in India, and I think Roshan or myself would host you someday when you are in India, maybe next year or year after, depends. Thank you very much, Peter. Thank you very much.
Thank you. It was a pleasure. I really enjoyed it. Thank you, and stay safe, guys.
Thank you, Peter. Thank you very much.
Thanks a lot. Take care.
Pleasure. Bye-bye.
Dear friends, we have a very interesting webinar coming up tomorrow. It is in association with Arthroscopy Society of Nepal and Arthroscopy Society in Nagpur, the topic being basic rotator cuff issues. So this is going to be the first session, and the second session will be on the 8th of November. So stay tuned on 1st November at 2 p.m. on our YouTube channel. Thank you very much.